Well, good afternoon. Thank you for inviting me today to speak. So my name's Andrew, and I'm the chair of the National Infusion and Vascular Access Society of the UK. And I'm going to talk to you today about the new national standards for vascular access and IV therapy that are imminently coming to be published to help with clinical practice in our hospitals. So a little bit about NIVAS board and how we got to the point of creating these standards. So we're a multidisciplinary board of 10 individuals. We are doctors and nurses, nurse consultants, paediatric specialist consultant nurses, and medical device practitioner consultants. So it's a range of people on the NIVAS board who are creating these standards. Now, the reason that we're writing these national standards, so we've been working with lots of organisations nationally for the past 10 years around vascular access IV therapy practice. And the RCN Standards, which were last published in 2016, needed to be updated, the RCN Standards for infusion therapy. And so we said to the RCN that we would take those on and we would update them and make them fit for the future for practice. And so you can see some of the organisations that we work with nationally are people like the MHRA, NICE, NHS England, National Patient Safety Network, Patient Health Protection Agency, and some of the collaborative work that we've already done that have fed into the new standards for practice. Things like Vessel Health and Preservation Tool, some of you may know about that. Working with the IPS, NIVAS has updated and created that tool. National Device-Related Infection Prevention Project, or DRIP, and that's definitely an infection prevention-driven initiative with support from BD industry and the IPS and lots of other organisations associated with vascular access, IV therapy, and actually urinary catheters. There's a couple of work streams there. We've recently published some paediatric flushing locking guidelines. Also Association of Anaesthetic Safe Vascular Access Guidelines we've contributed to. EPIC4, we're part of that working group. IVAS standards for infusion therapy, those are the American standards that we contributed to, and also some work on medical adhesive related skin injury. So it kind of gives you an idea of where we are placed nationally to kind of create these standards for practice. See that. So some of the associated resources that we've used to put into these UK standards, as I said, the IVAS infusion standards and also the new Canadian infusion standards, the Association of Anaesthetists. We also have published things like the NIVAS white paper around vascular access teams, flushing guidelines, flushing IV giving sets, antimicrobial delivery, and also the RCN prevention and management of sharps injuries. So, in terms of the new clinical standards for vascular access and infusion therapy, there's 150 plus standards. There'll probably be a few more by the time we've finished and are ready to publish. And it talks about things like vascular access device choice, insertion care maintenance, vascular access practice from peripheral cannulation and venipuncture up to placing midlines, PICC lines, ports, renal catheters, medical devices used in IV therapy and vascular access, so all of your pumping, ultrasound, vein location technology, complication management, infection prevention, obviously that's key, competence and training and where we think that should be for different areas of practice, elements of health and safety, including sharps management and also PPE. Talks about the LOCSIP, local safety standards for invasive procedures, competency, consent and safeguarding, and scope of practice and service delivery. So obviously I can't present every page of these standards because there's 160 so far of these standards, but I can give you a taste of what's included and explain the process, where we are at the moment and where we're imminently going to be before publication. So the first thing that the NIVAS board decided to do was have some core principles that would run through all of the standards in the document. And so the first standard would be, is intravenous therapy or the vascular access device clinically indicated? Is there an alternative? So we don't need to put the device in and give an intravenous drug. We can not worry about all of the associated complications. Brilliant. The second principle is around the vessel health and preservation concept, and that's really about thinking about what vein we're going to be placing the device in. Is the device appropriate for the whole length of treatment, and also how we're going to manage the device. And there's a lot more in it, but that's essentially the core principle. Then we talk about aseptic non-touch technique and upholding infection prevention standards. Talk about informed consent, the fourth principle, and patient engagement. And then the fifth principle will be around competence, training, and how people are maintaining their competence and education and scope of practice. So as I've said, the first standard 7.1 around the clinical side, is about, is that device absolutely necessary? Can we think of an alternative route? Have we thought about alternative routes for delivery of the medication? Could the patient have NG? Could they have PR? Subcut? There's lots of alternatives. So it's just about doing an assessment and putting that as a standard. So that should be something that everyone is doing to try and reduce the number of vascular access devices we're placing, or the amount of IV drugs. Then we talk about an organisational approach to vessel health and preservation, and that could be through having a vascular access service in your organisation, or having someone responsible for that concept of vessel health and preservation. So your practice development teams putting that into their training, education, so that we're considering the patient's vessels. And that really is about, we just want one device for the patient, so they're not having multiple sticks with cannulas, or they're not having multiple devices placed. And that could be as well around vessel identification with ultrasound or other technology. So we're just really reducing the number of times we put a hole in the patient into their vessel. Then standard 9.1, all intravenous therapy and vascular access device related complications, incidents and harms should be reported locally. So we did a massive piece of work last year on extravasation infiltration, where we looked at those injuries that were occurring outside of cancer, and we know that there are an enormous amount of extravasation infiltration injuries occurring in non-chemotherapy drug delivery. But what we also know is that most hospitals don't report them, they don't recognise them, they don't report them. And when you look at your instant reporting systems now, are they set up to deal with all of the complications associated with vascular access IV therapy? Because if they are, then we can audit those, we can look at trends, we can look at what's happening out there. So everyone knows what their infection, hopefully, everyone knows what their infection rates are, their CRBSIs, etc. Do you know what your exit site infection rate is? Do you know what your medical adhesive related skin injury rate is? Do you know what your extravasation rate is? So that standard is there to try and improve safety through audit and then education. Standard 9.2 will be around that local incident reporting. And then we've done a lot of work within NHS England with VAL, with the IPS around aseptic principles of asepsis, aseptic technique, and trying to standardise that language. So we've gone with principles of asepsis should be applied to all aspects of clinical practice associated with IV therapy and vascular access. And we've outlined what aseptic technique is, and then we've decided as a board, as a society, that we will use the ANTT framework principles throughout the document to reduce the infection risk, so key parts being avoided, etc. Then the glove the whole glove thing, the whole glove discussion, it's, you know, I'm very much not into gloves anymore, so I've let them go. But there is still a place for gloves in IV therapy and vascular access practice, and that is very much clearly set out in the standards. And what it talks about around glove use in standards is there's just 4 reasons why you would consider using gloves in vascular access IV therapy. The first one would be delivery of IV therapy that is deemed harmful to the practitioner. So that could be chemotherapy or monoclonal antibodies. And that's very much around a risk assessment undertaken by you as a healthcare professional in your organisation. Exposure to blood, and that would be so venipuncture cannulation, because there is a risk of blood exposure. So then we would want practitioners to wash their hands and wear gloves to protect themselves. Exposure, as I said, around taking blood samples and blood cultures, exactly the same, because there is that risk of exposure to the blood to the practitioner. And then finally, obviously for the insertion of a central venous catheter, we would expect a surgical glove to be used with surgical practice, but also care and maintenance of those devices, just to reduce the risk of exit site infection on our central devices. So those are kind of the 4 things that we really would expect glove use to be considered to be used. And that would still be a local decision, but you know, we get asked all the time what our position statement is in NIVAS around glove use, and that really is the only position that we have. And obviously throughout the whole standards, infection prevention is kind of a key element throughout the whole thing, and we've broken them down into different stages of practice and also different devices. Obviously for the whole thing around skin prep, we've talked about performing skin asepsis prior to device insertion, standardising that to using chlorhexidine 2% with alcohol 17%, and the solution should be contained within a sterile pack or applicator and be single use, and that includes those large bottles of fluid, and we see people opening bottles of you know, iodine, etc., and pouring them and then cleaning, and then they leave the bottle there and they keep using it. So this is a reminder they're single use, those bottles, so they should be thrown away after they've been opened and used on the same patient. It talks about products being, all products used for skin decontamination should hold a medicinal product licence, an ABD licence. Swabs and small wipes containing chlorhexidine and alcohol should not be used to decontaminate skin. They should be used for medical devices, and that is because we have seen a move towards using the small Clinell wipes, the small wipes in the green packets. The other ones are available. The trouble is that there's not enough chlorhexidine alcohol solution in those wipes to clean the area of skin necessary. Sorry, I haven't moved that on. Talking off my computer. To clean the skin, because what you need to do with your chlorhexidine applicator is clean the skin in the same area size of the dressing you're going to apply, up to 30 seconds with that motion. You can't do that for cannulation with a little wipe, a little paper wipe. And we see a lot of hospitals using those wipes because they're maybe more cost effective, but really the standard is at least 1 ml of chlorhexidine solution should be used. And then we talk about things like catheter lumens should be protected with a needle-free connector, and they should be decontaminated before and after each use. And those needle-free connectors shouldn't be taken off and then put back on. They should be discarded and replaced if they're taken off, and then we should be injected into those sorts of things, obviously. The vascular access device insertion exit site must be protected from infection which can migrate into the bloodstream, and then it goes on to talk about the different ways in which that could be done. CHG, chlorhexidine dressing, other foam pads, etc. Tissue adhesive can be used to seal the exit site to prevent migration of bacteria into the catheter site. It talks about the intraluminal space being protected with antimicrobial, antithrombotic locking solutions, So the standards are moving away from antibiotic locks because we know that antibiotic resistance is a risk. So we want people to start thinking about non-antibiotic solutions that are antimicrobial, and there are some new locking solutions that are available now that are not just antithrombotic, they are also antiseptic, will kill Candida, will kill MRSA, MSSA, and they also will eradicate biofilm from the interluminal space. And so when you do those three things, you can salvage and you can protect the catheter. So it talks about that as well. And other things in there, things like ultrasound probe. So we advocate in the standards that we should be using vein location, vein visualization technology for things like cannulation and midline insertion for difficult IV access patients. And now remember that in your hospitals, up to 90% of patients will have some form of vascular access device, IV therapy, when they're an inpatient. And we know that 50% of those patients will be difficult IV access patients. That means you won't be able to see or palpate a vessel, which means they'll have repeated cannulation attempts. And if you don't have a vascular access team in your organisation, those patients are at high risk of complications, not just infection, but as I said, but things like thrombosis, medical adhesive related injuries, extravasation infiltration because the cannula has dislodged or not been sited appropriately. So we want people to start thinking about using technology like ultrasound, and when you use ultrasound, Health Protection Agency published some guidelines recently about using sterile ultrasound gel and not using the bottles of ultrasound gel. Now in vascular access practice specifically, you need to make sure that the probe is sterile and that the gel is sterile and that the skin that you're looking at has been decontaminated with chlorhexidine and alcohol first before you even look at a vessel. Because if you use a probe, a sterile probe, if you use a probe with sterile gel but don't put a probe cover on the probe and don't clean the skin, there's little point in using sterile gel. So the standard around ultrasound cannulation, ultrasound vein visualization will say, clean the skin in the area that you are going to look with the ultrasound, allow it to dry, then use a sterile sachet of ultrasound gel, and then use a sterile probe cover to look at the vessel, and then you can cannulate in real time straight away. Even if you're going to look and then come back within 24 hours, you still need to do that process. And that is an evidence-based thing, so that's in there as well. And we talked about protecting the vascular access device insertion site, and we talk about visually inspecting that site. And, you know, we don't use the term VIP score because VIP score is a visual infusion phlebitis, but we use the term phlebitis score. So if the patient has signs of phlebitis at the exit site, and if there is a phlebitis of, you know, any redness, pain or swelling, just remove that device. If you're using VIP scoring, the VIP score says VIP score of 1, observe, VIP score of 2, remove. But if you've got a VIP score of 1, it's red, painful, it's only going to get to a 2 or a 3. So you're basically watching that exit site evolve into more of an infection. So the new standards will talk about any complication at the exit site, redness, pain, swelling, remove the device. It also says that we want to look at these, do these assessments, a phlebitis assessment of that exit site at least 8 hourly, basically every shift, so morning, afternoon, evening, night shift. So we want to make sure 3 times a day people are looking at their cannula sites. And that is because we know that that is a real risk. It's a short catheter, an exit site infection can quickly go into a bloodstream infection. Sterile single-use vapor-controlled dressings, that's just, you know, pretty standard. And if someone's allergic to chlorhexidine, alternative antimicrobial silver or foam dressings can be used. Because we talk about looking at the exit site, and particularly with a medical adhesive-related skin injury, which can often be mistaken for cellulitis or an exit site infection, we are obsessed with being able to see that exit site, but actually we can treat that exit site with like wound care dressings, And we don't need to see it if it's already red and inflamed and we're treating it. We can do that with things like silver dressings. So those are in there as well. Standard 15.3, steps should be taken to minimise the risk of PIVC-related complications, infection. ANTT must be used. Intended cannula site should be decontaminated with chlorhexidine for at least 1 ml of solution, as I've said. Cannula site should not be palpated after the skin has been decontaminated prior to needle insertion. And that's because people might, they'll clean the chlorhexidine on the skin, and then the first thing that they will then do is palpate before they put the cannula in. And they've put a glove on, but it's not a sterile glove, and they've probably touched loads of things before they get there. So that's a reminder in practice, don't repalpate your decontaminated skin before you cannulate. If you're a novice and you're learning to cannulate, then the standards will say, that's fine. If you need to repalpate, wear a sterile glove. It goes on to talk about things like PIVs are for short-term and non-vesicant drug administration. PIVCs are not for vesicants, they're not for drugs with osmolarities above 600. The evidence there around it's not necessary to routinely change the PIVC after 3 to 5 days if there are no complications, that we can keep cannulas in for as long as clinically indicated. But it does also go on to say that the organisation should have something in place to ensure that those cannulas are monitored so that we're not just being left in and forgotten, which is sometimes something you can see if you're an organisation that has cannulas left in for clinically indicated practice. And the smallest gauge PIVC should be used as far down the arm as possible, away from joints and points of flexion, which allow turbulent blood flow around the catheter to reduce the risk of mural thrombosis and mechanical phlebitis. So we shouldn't just be putting a 20-gauge or an 18-gauge cannula in the antecubical fossa. So if there's any A&E nurses here, we want that to stop. And we shouldn't be putting things like amiodarone through those cannulas. If you work in oncology and you're putting peripheral cannulas in, are there any oncology nurses in the room? No, you're all infection control nurses probably. If I said to the oncology nurses in the room, they would use a 24-gauge cannula for all of their treatment. And that yellow cannula then allows a turbulent blood flow around the device in the vessel. It doesn't matter what drug you put into the cannula, but it matters how big the cannula is and where you site it. So we want sort of the forearm as the first choice, and we want the joints as the last resort. So we're not saying you can't, we're saying that you should work your way up through, and it should be based on flow rate requirement and vein availability. We'll just go on to things like in clinical venipuncture. So a sharp, safe system should be used to minimise the risk of needle stick injuries. Closed systems are safe. Cannulas that are closed system that have blood control mechanisms protect the inserter, so they should be considered for use. And then steps should be taken to minimise the risk of PIVC-related complications. So also midline peripheral cannulas are inserted into a peripheral vein of the upper vein, cephalic vein or brachial vein. The catheter tip should terminate the axilla in adults and children. So there's a lot of, if you work in vascular access, there's a lot of discussion at the moment about midline catheters that go into the upper arm and the tip going past the axilla, and we're very clear in the UK standards that that is the safest place for the tip to go. And then finally, talking about some things that have come up recently. So vascular access devices should be flushed regularly during care and maintenance, and should be to ensure patency, and also to ensure that no drug residue remains, and that's something that the National Patient Safety Team have asked us to include. Intravenous giving set should be flushed when the infusion is finished to ensure any residue drug within the giving set tubing is administered to the patient in full, particularly important during antimicrobial administration, because your giving set, depending on the bag of fluid that it was in, you could lose up to 20-30% of the drug in that giving set if you don't flush it through into the patient. And then a locking solution should be used post-vascular access device and during care maintenance to ensure that it remains free from infection. We are also then going to advocate the use of pre-filled saline flushes, and that's because there's lots of evidence included around them reducing the risk of infection, cross-contamination, sustainability, and cost to your organisation. So drawing up a saline flush in the traditional way will cost you 72 pence. Pre-filled saline flush will be 20p or less. So imagine the number of saline flushes you give in your clinical practice, massive saving to the organisation. Also, we want to stop this thing, and this happens in many hospitals, this thing around communal saline flushing. And that happens more than you would think. Most people are shocked to see that, but I get told by our NIVAS members that is something that pharmacy will recommend to them, particularly in times when saline ampules are not available. They will just hang a bag of fluid in their drug room with a needle-free connector and a blunt fill needle, and they will just take their flushes communally from there. And obviously the standards will say that isn't okay to do, don't do that. So finally, the final version we hope will be finished in May 2025. In actual fact, there are just 6 more sections to write before it's finished. And so hopefully by next week we can start doing the proofing to the board, and then consultation with the NIVAS partners, which should happen before June hopefully, but by June. And then we'll aim for publication of the first version in July with a 6-month consultation, so it may well change within that time, with a proposal at NIVAS conference and the submission to the RCN for accreditation. And then also launching this year, alongside those guidelines, will be the Advanced Vascular Access and IV Therapy module at level 7, which we've written, which will be launched at Vascular University, which will enable particularly people in vascular access and IV therapy to gain a qualification nationally that will be recognised and standardised. So that's a very brief kind of introduction and overview of the standards. We were hoping that they'd be finished by now, but obviously you can imagine it's a big task, and we want to make sure we get everything in there. So they are nearly finished. And if there's any questions, I can take them now, but also you can contact us through the NIVAS website if you've got any questions as well. Thank you.